All right. So, hello everyone. A very good evening to all of you. I am Dr. Tushar Mehta, orthopedic surgeon and faculty of orthopedics. Well, today in this INI-CET predictor series, I will try to cover one of the few important MCQs which have been covered, which have been asked in INI-CET, and what not only we think, but it is our intuition and gut feel, guesswork, as you can say, for your coming INI-CET exams. First question is in front of you. Which of the following vertebral fractures involves disruption of ligaments of anterior, middle, and posterior column? See, I don't know how many of you have tracked this in the past or not, but INI-CET is an exam where what I personally feel and what I personally have observed is that most of the times, whatever these questions which are being asked, they're usually from anatomy. A significant component is not from anatomy, it is from applied anatomy. So anatomy of spine is very important. There are 3 columns. Dennis has given those 3 columns. I'm sure most of us are already aware. Anterior column, middle column, posterior column. So there is one fracture which is, through and through from all the 3 columns. That is what is called as chance fracture. Also what is called as jackknife injury. Also what is called as seat belt injury, also what is called as seat belt injury. So it basically involves all the 3 columns of spine in one shot. Clay-Shawler fracture is something that you see in C7, you see in T1. Out of the 2, if you have to choose one, then definitely you always should choose C7 over T1. Wedge compression fracture is usually due to osteoporosis. It is the most common cause for wedge compression fracture, and it is usually seen in lower thoracic spine. Yes, Dr. Swagat Lakshmi Das is absolutely right. In chance fracture, there is no second chance. Jefferson fracture is a fracture of C1. It is a fracture of C1. It is a fracture of the atlas, and it is primarily a burst fracture pattern. All right. So it is primarily a burst fracture pattern. Clay-Shawler is primarily an avulsion type of fracture pattern. It is an avulsion where a strong contraction of a ligament leads to avulsion of the bone. So these different fractures of spine occurring through different aspects of anatomy of spine, this is something important. In INI-CET, as I said, that if you go through the previous record, the track record, you will find many questions from anatomy, applied anatomy. There is one more thing that we've seen. They usually put up a clinical presentation, and that clinical presentation is a very long stem clinical question where they will describe the antibiotics and blood counts and this and that. Some of the lines on that clinical stem are not even useful. So one has to be intelligent enough to read between the lines and see what is important, what's not. So let's read the first line. A 13-year-old male. So first of all, 13-year adolescence. I want you to have a picture in mind that we are talking about an adolescent. Male by his parents. Yes, please come in. 13-year-old male is brought in by his parents for right hip stiffness. Guys, just 1 second. Thank you so much, ma'am.
Yeah. Black and white and color.
Thank you so much. Thank you.
Should I keep the belt on, sir?
Yeah, please, if possible. Thank you, ma'am. So, a 13-year-old male is brought in by his parents for right hip stiffness and groin discomfort. So, see, this has to be something related to hip for sure. There is no confusion about it. After activity, he feels well otherwise and denies fever. Now, this is a path-breaking line. He denies fevers or chills. This is something which is very important. He denies fever. Okay, I don't want to read the question further. I want to just take a look at the option. I'm getting a little impatient. So, septic arthritis. Do you expect any septic arthritis on this planet without fever? I don't think so. I don't think so that I expect any septic arthritis without fever. Do you expect any synovitis without fever? Well, I don't think so. There is any synovitis on this planet without fevers and chills. Let's read further. He's ambulatory, that's okay. With a slight limp. With discomfort in internal rotation. See, if somebody has discomfort in internal rotation, that means that there is too much of external rotation. Anyhow, two options: congenital hip dislocation, SCFE. Even though I have zilch, I have zero idea of these conditions, still that won't be a problem for me. I can tell you why. See, I can tell you why. Because in congenital hip dislocation, the problem has to be congenital. So, I mean, if the problem is congenital, we do not expect, the patient to present at 13 years of age. So we actually find it a little funny that if the problem is, coming to you at 13 years of age, I don't think so that, we have the right to think about congenital hip dislocation, because congenital hip dislocation would have come quite early. And of course, 13-year adolescence, excess external rotation. So everything is going towards the favor of SCFE. So here, what do we learn is that what I have seen over a few years is that NICT paper. I don't know whether you people will agree to this or not, but NICT at the first go looks very easy. The first go looks very easy. It's like it's a cakewalk. But then when you probe inside it, then you find out that question has hidden layers into it. Depth hai. So that's very interesting in this pattern of paper. All of the following are done in osteoarthrosis except osteoarthrosis is nothing but osteoarthritis. Now, entire word, like, okay, fine, if I have again zero idea about this question, then there is, I think, everybody must have heard about knee replacement, hip replacement. And when do we get it done? Whenever there is a significant arthritis, we get arthroplasty, we get knee replacement done. So they have asked all of the following are done in osteoarthritis except, all of the following are done in osteoarthritis except. So arthroplasty is basically joint replacement. So this is surgical replacement of a dead, degenerated joint with a new artificial one. Okay. Of course, we do that. No confusion about it. Osteotomy. So there is something called as high tibial osteotomy. There is something called as proximal fibular osteotomy, and it is something that we do very often. High tibial osteotomy and proximal fibular osteotomy is something that we do very often. Basically, it is for alignment correction. Basically, when it is done for alignment correction. So we're just correcting the alignment. We're doing the genovarum and all. Arthrodesis. Now, arthrodesis, not many of you must have heard about arthrodesis, but yes, we do arthrodesis. Osteoarthritis is of two types: primary, which happens due to age; secondary, which has some underlying cause. One of the common underlying cause is trauma. Okay, so one of the very common underlying cause is trauma. So when I say trauma, what does that mean? Post-traumatic arthritis. Now, in post-traumatic arthritis, there is no other option. Of course, you can replace a joint, but if you think it is not replaceable for some reason, then we go for arthrodesis. We go for surgical fusion of the joint. To alleviate the pain, to relieve the pain of a patient, we fuse the joint. So we go for surgical fusion. But we never do synovectomy. I'll tell you why. Because synovectomy is done in another condition called as rheumatoid arthritis, because over there you see erosive synovial pannus. Alright, over there you see erosive synovial pannus. See, in osteoarthritis, always remember that what is the primary layer involved in pathogenesis? What is the primary layer involved in pathogenesis? That is articular cartilage. In rheumatoid arthritis, what is the primary layer involved in pathogenesis? That is the synovial membrane or the synovium. So you have to understand it in this way. Done? Now let's talk about the next question. So question number 4. Which of the following fractures of the neck of the femur are associated with maximal compromise in the blood supply? See, it's very simple that they are categorically asking you about a classification. So that classification is what is called as anatomical classification. So I can see one question by Dr. Hindiwala. If your question is still not answered, just let me know. I think I have told about arthrodesis, but if you still want me to repeat, I can, no problem at all. So there is one thing called as anatomical classification of fractured neck or femur. Again, I would come back to my actual point that it is important. This classification is important because it gives us a sense of a very important concept of blood supply of the hip joint. I'll tell you how. So if you have a head of the femur like this and a neck of the femur like this, then let me show it to you that you can have 3 fractures of the neck of the femur. This is 1, this is 2, this is 3. So according to the anatomical classification, fracture neck of femur is divided into 3 types. Now this fracture is at the base of the head. So let's call it subcapital fracture. This fracture is through the neck. So this fracture is through the neck. Let's call it transcervical fracture. This fracture is at the base of the neck. So this is what is called as basicervical or basal fracture. I hope we make some sense here. So one fracture is at the base of the head, another fracture is through the neck, another fracture is basically, at the base of the neck. So that is what is called as basicervical. Now what I want all of you to understand here is a very, very simple thing, that as proximal you go, as proximal you go, more will be the difficulty in the blood supply. See, we all are aware that hip joint has got an exceptional blood supply. Now when I say exceptional blood supply, what does it mean? That it is retrograde, it is from distal to proximal. By the way, which other areas have got a retrograde blood supply? Can anybody mention in the YouTube box, the chat box? It is hip joint, it is scaphoid, it is talus, and it is patella. So they have retrograde blood supply. So more proximal you go, the worst damage will be there to the blood supply. ठीक है, जितना आप ऊपर जाएंगे फ्रैक्चर लाइन में उतना डैमेज ज़्यादा होगा ब्लड सप्लाई का, उतना इवन ज़्यादा होगा, उतना प्रोग्नोसिस पोर होगा. So this is basically fracture neck of femur, and there is one more fracture here which is the intertrochanteric femur. So which is the most proximal out of all these? Subcapital. So answer has to be subcapital. I hope my concept made some sense here. So again, I would reiterate what I said just about a few minutes ago, that we have to understand that we have a anatomy with us, and then we have to apply that anatomy, and that is what orthopedics is about. Now clinical tests, they're a rage for some reason, which is of course not known to us, but they're a rage. And test for carpal tunnel syndrome is one of the most frequently asked topic. Is there any noise? Dr. Das, is there any problem? Is there any noise that you can hear? Just let me know. I think I have, because that's one more thing. I had to cancel the session of day before because of my laryngitis. So chronic laryngitis, and immediately I developed a acute episode, and therefore I am on a voice rest. Okay, I think it's fine. So all of the following are used to diagnose carpal tunnel syndrome except. So for carpal tunnel syndrome, there is one test that everybody knows, is what is called as Phelan's test. Now when I say Phelan's test, that simply means that you ask the patient to stand with approximation of dorsum of both the hands, and make the patient stand like this for about 50-60 seconds, and then within 50 seconds patient tells you that there's numbness in the hand. So it's a provocative test. Then we have something which is called as Tinel sign. Tinel sign is basically when you tap the median nerve, tap over the median nerve inside the carpal tunnel, and if it produces tingling and numbness, that is called as Tinel sign. That's again a provocative test. What do you mean by EDS, electrodiagnostic test? That is basically nothing but nerve conduction velocity and electromyography. Nerve conduction velocity, electromyography. So you see sensory latencies, you see motor latencies, you give a stimulus to the nerve, and then you see how much time it takes to fire and all. Addison has nothing to do with carpal tunnel syndrome. It is clearly seen in a condition called as thoracic outlet syndrome. So it is clearly seen in thoracic outlet syndrome. Also known by the name of cervical rib. Now there is one more test for carpal tunnel syndrome. Actually there are 3 tests. One is Phelan's, one is Tinel's, and there is one more test here, that is what is called as Durkin's. Out of these three, Durkin's is the best. Yeah, so that's about it. A question which has been asked in the past, if you must have seen the previous year questions, then you must have seen this question in the past: which of the following bones does not contribute to the formation of the wrist? So radius is important, scaphoid is important, lunate is important, triquetrum is important, even the articular disc of ulna is important, but ulna is not important. Ulna, ulna, na, ulna, na chahiye, ulna, na, not applicable. Ulna is not required in formation of the wrist. So what I'm trying to tell you is, sometimes they will surprise you. They'll scare you, but they'll surprise you as well. And they'll surprise you with the easiest questions, and they will be like, INICET, and what am I doing here? It is supposed to be something big, but this is what the beauty of this paper is. When it was AIIMS, I remember that sometimes we used to see, and we used to actually start having a feeling that how the hell is this possible that an AIIMS paper is having this kind of a question. So they will surprise you as well with the easiest possible things. Which of the following is true about developmental dysplasia of hip? So now it is 10 times more. This is what I'm trying to tell you. This pattern of question is now a rarity, but still we have to discuss one, just to tell you that statistical based questions, fact based questions, data based questions. So it is 10 times more commonly seen in twin pregnancies. Wrong. This condition is 10 times more commonly seen in breech delivery with extended knees and legs. Breech delivery with extended knees and legs. Right hip is more commonly involved than bilateral hip. Absolutely wrong. It is the left hip which is more commonly involved than bilateral hip. MRI is the best screening tool in neonates in high risk cases. No, it is not MRI. The best screening tool is USG. So the investigation of choice for screening here will always remain USG. The investigation of choice for diagnosis overall will always remain MRI. Now option A: excess hypertrophic ligamentum teres prevents successful close reduction of the head of the femur. Excess hypertrophic ligamentum teres prevents successful close reduction of the head of the femur. This is absolutely true. And that too, one should remember, before the age of 6 months. After the age of 6 months. So if you do a close reduction till the age of 6 months, it's fine. In this problem, if you do a close reduction till the age of 6 months, things are fine. But if you postpone the problem to the age of more than 6 months, then there's a significant soft tissue accumulation inside the sternum that won't allow you to put the head of the femur back via close reduction, and in that scenario, you'll have to go for an open reduction. So that is why less than 6 months treatment is close reduction, more than 6 months it is open reduction. So that is about it. One image based question has to be there. Either it can be on a splint or a traction or a cast or an implant or an instrument, something like that. Guys, if the cast would have started from here, if it would have gone here, we would have called it above knee cast. If the cast would have started from here and it would have gone here, we would have called it below knee cast. If the cast would have started from the middle of the thigh and would have finished just above the malleoli, keeping the ankle free, I would have called it cylinder cast or tube cast, which is commonly used for fracture of the patella. Now, if you see this cast, it is not a typical AK above knee, it is not a typical PK below knee, it is not a typical cylinder or tube. It is something which is bearing the patellar tendon. So you have patellar tendon, ligamentum patelli, and it is connected to a bone called as tibia. So if you have a fracture of the shaft of tibia, then this PTB cast is used. So it is patellar tendon bearing cast, basically used for various conditions, but the classical condition is fracture shaft of tibia. Alright, so it is PTB cast used for fracture shaft of tibia. Alright, done everyone. So PTB cast classically used for fracture of shaft of tibia. Done, everyone? Again, as I said that clinical test is a rage. So this clinical test was asked in the simplest way, like a theory thing. Otherwise, what they can do is they can ask you a clinical question in the form of an image. So this patient is standing with dorsum of his hand approximating the lumbosacral joint. All right, dorsum of the hand approximating the lumbosacral joint. Then dorsum of the hand approximating the lumbosacral joint means palm is facing outward, and if somebody puts his hand on his palm, if I put my palm on his palm, and if I ask him to lift off my palm, and if you can see in the second image, if he is able to lift it off, then we are going to call it Gerber, Gerber, whatever you want to call it, lift off test. And then we are going to call it Gerber, Gerber, whatever way you want to call it, lift off test, Gerber's lift off test. It is done for this tendon here, that is what is called as subscapularis, and basically it is checking which movement at shoulder, internal rotation. If you go through the previous papers, you will find this question asked very frequent. Sometimes they ask this straight question that identify the test. Most of the times what they've done is they've given the test, but they've not asked the muscle, they've asked the rotation, they've asked the movement. Internal rotation is checked via this. So if you see this, I'm sure most of you would agree that you can see a talus, you can see a calcaneum, you can see a cuboid, you can see a cuneiform, and navicular is not clearly seen. So the size of navicular has been reduced to that of a biscuit. The size of navicular has been reduced to that of a biscuit. So basically, I mean, we all are aware of the fact that there is a condition called as osteochondritis, which is of two types. One is called as the pressure or the compression type of osteochondritis. The other one is called as the traction type of osteochondritis. Now, when I say pressure or compression, then Kienbock is one disease which basically involves lunate. Kohler is another disease which basically involves navicular. Then Panner is another disease which basically involves capitulum. Then Freiberg is another disease which basically involves metatarsal head, particularly second. So in all these four diseases, what you are going to see is a pressure or a compression or a crushing type of a force leading to osteonecrosis of that underlying bone, and whenever a particular bone is involved, that particular condition is named a particular disease, and which is the name is in front of you. With this question, I want to tell you that certain questions which are asked are you can't help it kind of a question. I mean, there is no concept. If you remember, it's Kienbock, not Kohler, or Kohler, not Kienbock. I mean, you have to remember it. You can make that concept, Kohler, yeah, washroom fittings, Kohler. No, you can't. This is a clear-cut question in front of you where a bone is gone. Now you're confused whether it is Kienbock or Kohler. Then something should come to your mind that Kienbock is lunate, Kohler is navicular. So upper limb is Kienbock, lower limb is Kohler. So this is basically Kohler. Alright. Now traction osteochondritis, you have something which is called as, one disease I'm telling you, which is called as Osgood-Schlatter's disease. It basically involves tibial tuberosity. Then there is one more disease over here, Sever's disease. That is what is called as calcaneum. In these two diseases, some muscle or tendon must be applying a traction or a pull to the bone. So that is traction osteochondritis. As I said, image-based question from splint has to be there. You can't help it. So it's a cock-up splint is something that you see for radial nerve palsy, that is basically wrist drop. Knuckle bender splint is basically ulnar nerve palsy, also what is called as claw hand. Aeroplane splint is basically brachial plexus palsy, what you are looking at right now. Turnbuckle splint is basically used for a condition called as Volkmann ischemic contracture. So I hope I made some sense to all of you. So basically what I want all of you guys to understand is a very, very simple thing here, that this question, that identify the test being performed. So this is basically Phalen's test. If you are tapping the median nerve, that is basically tunnel sign. If you are applying a direct pressure over the carpal tunnel, carpal compression test, that is Durkin's test. Allen's test is to check the patency of superficial palmar arch. All right, that's about it. All right, so with this we come towards the end, and not in fact the end, but I want to talk to you about a few things. See, please try to understand that the first fundamental of INI CET as far as orthopedics is concerned is applied anatomy. I give you a few examples. Which of the following bone does not form the wrist joint? Allah. Retrograde blood supply seen in hip, talus, gifford, patella. Dennis three column concept, which fracture will cross all the three columns. Second, image based fracture, X-ray based fracture. Now that can be Barton, that can be Schofer, that can be Smith, that can be Coley's, that can be Galeazzi, that can be Montigia, that can be Nightstick, that can be Greenstick. So far so good. Clinical test, most likely image based. Now when I say clinical test, most likely image based, what does that mean? That can be Phalen's, that can be Durkin's, that can be Tunnel, that can be McBurry, that can be Apley's, that can be anterior draw, posterior draw, Lachman, Ottolani, Barlow. So either of these image based test has to be there. There has to be an image on a surgical modality. When I say surgical modality, what does that mean? It can be K-wire, it can be K-nail, it can be tension band wire, it can be bone clamp, it can be reduction forceps, it can be a plate holder, it can be a bone holder. The next thing, again an image, but this time this will be of a splint or a traction or a cast. Now Bowler Brown, Thomas, cock up, knuckle bender, traction gallows, cast, it can be above knee, below knee, cylinder, POP, handshake, glass holding, reezer, something like that. One question has to be related to polytrauma. Patient, run over injury, by car, blood at the tip of external urethral meatus, hypovolemia, hypotension, tachycardia. What are we suspecting? Fractured pelvis. So, cut to what should we do first? Airway, breathing, circulation. Not airway, hair circulation is a priority because it's a catastrophic hemorrhage. So in circulation, what do we do first? We give fluids or we do something to control the bleeding? We give something to control the bleeding. What is that? Pelvic external fixator. So something related to that. Then one question, there is no confusion, has to be oncology. There has to be an X-ray which will be later on, once the recall will happen, which will be claimed by either Dr. Sumer sir or me that it belongs to radiology or orthopedics. But yes, since he must have, he has taught you the beautiful aspects of radiology, all the GCTs and ABCs, and the way he has explained it to all of you, and I have as well, to the best of my capabilities, that physis is seen, physis is not seen, and all that thing, how to differentiate GCT, ABC, and sunray, and soap bubble, and onion skin. So that question has to be there. Nobody can stop it. Similarly, one question is most likely from sports medicine. Now, when I say sports medicine, that can be Bankart lesion, Hill-Sachs lesion, that can be supraspinatus tear, that can be meniscal tear, that can be collateral tear, cruciate tear. The way I have explained in my lecture that somebody had a fall, but he got up on his own. He came to me on his own, meniscal tear. Somebody who did not slip and fall, but just twisted the knee, now can't walk, collateral tear. Somebody who had an injury from the front and it's a painful swollen knee, we're talking about a cruciate tear. So something related to that. One question will be there on investigation of choice or gold standard investigation. Let's say, for example, pot spine. Investigation choice MRI, but gold standard is CT guided biopsy. For all knee ligament injuries, most of them investigation of choice is MRI, but gold standard is arthroscopy. So something related to that. Or maybe a patient with septic arthritis, what is the next step? UC guided aspiration, but what is the best step? Arthrotomy. So something like that. So these are 8-9 predictions. It's a predictor series, right? So if it is a predictor series, excuse me. So if it's a predictor series, then I must give you prediction. No? So that's why I'm giving you the prediction. So this is my prediction. So these are the few predictions that I'm giving you right now, and I hope they help you. Thank you so much, everyone, and I wish you guys all the best. Do well, study well, work hard. At the end of the day, every exam is just a small part of your life. It's not your life. So just show up. That's all. INICET, I just say one thing: show up. Many don't. So just show up and just revise the previous 3-year, 5-year question papers, and you will see questions from the topics. I mean, they don't change the topics; they change the questions, but they usually keep the topic. They usually keep the topics somewhere same, or I would not say same, but at least relevant to the existing topics. So I wish you all the best, and God bless all of you. Take care of your family, take care of everybody around you, take care of yourself. Thank you so much. Bye-bye.